Hello, David. Thank you for coming in the Optomask. Is it okay if we ask you some questions?
Thank you very much for inviting me. Of course, it's okay to ask me questions.
So the first question is just the usual question. If you could just introduce yourself, that would be brilliant.
So I'm David Janicek, one of the eye doctors. I'm been working in Swansea for 20 years now, and currently I'm a lead of a cataract service in Singleton Hospital.
Fine. And a lot of common questions is about the types of cataracts. If you go through, got some pictures, obviously put it on the screen. But if you want to discuss the first type of cataract on the screen itself.
Yeah, first things first is I don't think the type of the cataract is that important in how we grade the cataracts, but it's for description more or less. As you can see on the picture on the top left, that cataract we call nuclear sclerosis. So as we get older, the nucleus of the lens will become a little bit more brown colored, and it'll lead to index myopia as an initial stage or initial signs of cataract, and then progress and make vision blurry. So that's the first type of the cataract, is nucleosclerotic cataract. In my experience, this cataract usually progresses quite slowly and leads to maybe frequent glasses change, if anything, really, before it makes quality of life issues for the patients. On the top line on the right, you can see another type of the cataract, which is cortical. And very often patients can achieve quite good visual acuity with this type of cataract, but it will cause more symptoms alongside glare, maybe when driving at night and things like that, okay? And again, it can progress from periphery, which is not really important and doesn't have to be addressed, but usually these changes do progress in the visual axis, and then we can deal with it by doing the cataract operation. On the bottom of the picture, you can see potentially the last type of the cataract that needs to be mentioned, and that's posterior subcapsular cataract. And that is the one that seems to progress sometimes more rapidly, so may affect quality of vision fairly quickly and lead to quite good disability, even if patients are waiting, less than a year for the operation. And the first sign of that cataract is typically glare from bright lights as well.
Right. And how would these types of cataracts, would they affect the type of the surgery, or would they take into consideration?
Not really. So in practical terms, it makes no difference to the surgery at all. We deal with them the same way, and the only time that it does affect the surgery is when the cataract becomes too advanced and prevents any fundal examination and affects the red reflex. This may lead to potentially more problems and more risky operation. But these types of the cataract doesn't really affect much what we do when we operate on patients.
How would you grade these cataracts? Often enough we see optoms ranking NS+++. Or...
To be honest with you, I usually, the plus system is good, but I think for me, the main piece of information I need when I grade the referral is the visual acuity, really. It's kind of surrogate to quality of vision overall, and you may elaborate on the referral a little bit more about the individual effects on the quality of life. But I think when I look at the referral, I look what the visual acuity is for the patient, and that's really about it, really. So I don't think the grading of the cataract is essential. You may make comments on if it interferes with any other things you would like to do. So if it interferes with fundal examination, or for example, driving or work, obviously those are important facts, but we'll mention them later on.
Fine. When is it, obviously, that leads to the next question, is when is it appropriate for optoms to refer for cataracts?
That's a good question. I think I know the difficult position optoms are in, really, when the patients sometimes come with a complaint and it's only beginning. So I think the main rule for me would be refer the patient when the patient has a problem. I would try to encourage avoiding referral patients who don't have any problems, although they may have a bit of a cataract present and you may see a little bit of a cortical opacity or a little bit of nuclear sclerosis. I think they may be happily leaving it alone, and when they come for pre-assessment, sometimes things don't change much, and then they actually asking why they are referred, and we do have a bit of a problem with capacity. So I would encourage opticians to refer patients when they start having problems.
Right. And how do we expedite a cataract referral? Because often enough patients realise there is a 2 years waiting list, and they come back to the opticians, see in view of trying to being moved up on the waiting list.
So I think we are getting a little bit better, but the situation is variable. So we try to see the new patients to 52 weeks target. So usually we see new patients, new referrals within a year. So the 2 years waiting time for now is not the case, is now about a year. But as I said, there are cataracts which may progress more rapidly within that period. So in the comment section of your referral, it is important to mention how it affects the patient. And like many things in medicine, it is individual. So we may expedite a patient with visual acuity 612 if, for example, they work as lorry drivers. Same, we may expedite somebody who needs a glaucoma fundus photograph and we can't achieve that. Or somebody who's looking after a relative, for example, and needs to be able to drive for that. So again, there is no set criteria for expediting. When I read the referral, the main thing is the visual acuity again. So we automatically expedite patients who can be registered sight impaired or partially sighted. Those are expedited even without any comments on the comment section. But we can expedite patients on other circumstances, like I mentioned before.
Fantastic.
So if the cataract is affecting their ability to work, ability to look after anyone or themselves, for example, diabetics needs to be able to dose their insulin doses, they need to be able to see quite well. All these circumstances are taken into account.
Fantastic. So you've got the referral letter from the optometrist. You can grade them. We've got a grading card system within this hospital. If you run through how that works and...
So generally speaking, our booking office now wants a time target. So we decided to categorize cataracts into, broadly speaking, 3 categories. One would be a routine referral. So those would be the cataracts which are affecting the quality of life, obviously, but haven't got any of the issues I mentioned above, and the visual acuity is below 0.5 logMAR or 618 in the old money. We don't expedite those and we grade them as a routine. So they would, generally speaking, be waiting 52 weeks to be seen.
Fine.
If they fulfill the visual acuity criterion, we expedite them. And again, we can decide about 2 categories. So one category is urgent cataract within 6 weeks. And those would be the ones who really can come into harm by not having the cataract surgery soon. Okay? And again, it's not always absolutely on visual acuities. It may be the circumstances, if they are at the risk of tripping over or they have actually fallen or broken something. So that will be the most urgent category. And then there is a category of urgent within 12 weeks where people are somewhere in the middle. And it is for the clinical judgment really to decide which is more appropriate.
Fine, fine. And what are the latest developments in the cataract world or field?
I don't think there's much in terms of changing how we do the cataract operation. That's been refined over decades, really, and we had 50th anniversary of invention of phacoemulsification. Right. So the most is about making things efficient, really, and try to get through more cases. So we're trying to introduce bilateral cataract surgery into the service, same-day bilateral surgery, which obviously saves us pre-assessments, visits to optoms, and visits to the hospital. And we are performing maybe 5% at the moment as a bilateral. Patients suitable for that would again be very routine cataract operations with potentially no other comorbidity and with a low risk of complications. And they also have to be cooperative enough. So when we sit them on a slit lamp and they tolerate the bright light, we can expect that they will tolerate bright light with a microscope as well during the operation. So they're suitable for topical anesthetic. That's an important thing in patient selection for this sort of approach.
Fine.
And also it has to be their wish. So it's a patient's choice. We don't push anyone to have bilateral surgery on the same day. If patients wish to have one eye at a time, we'll do one eye at a time.
Fantastic. And how long does the procedure take?
So the whole process from admission to discharge from the hospital building, it's about 2 hours. The surgery itself, we book patients for half an hour slot, maybe 20-minute slot on the high volume list. So anything between 20 minutes, half an hour, I would say, should be enough to do a routine cataract operation.
Fantastic. And we've done a video about what patients to expect and what to look out for, but briefly for optometrists, what would patients expect after their surgery? Do you get an idea?
So after the surgery, there is obviously a bit of discomfort from the operation. That comes from the corneal incisions and potentially side of the subtenon injection. These are like little scratches on the cornea, little corneal abrasions which need time to heal. There is a bit of a blurring expected through corneal swelling, and you can see it on the slit lamp in the early days. By the time they come to see the optician in week 4, most patients will not have any of the corneal swelling and they should be resolved by then. What else? They may experience a bit of a redness, and again, this may be due to little subconjunctival hemorrhage, sometimes more often when we use subtenon injection. This redness is cosmetic really and resolves a bit like a bruising within a few weeks.
Common complications post cataract?
The most dreadful complication is thankfully very, very rare. So we aim every information for the patients, and maybe optometrists should be aware of it, or they obviously are, is detecting early signs or earliest signs of infection. So infection, the most risk of infection is within the first week after surgery.
Right.
And the signs would be decreased vision, which potentially previously was not too bad. So drop in vision, drop in quality of vision. Increased pain is one of the early signs as well. And potentially discharge from the eye as well. So if patients within the first week experience deteriorating vision, more pain, they need to be referred to hospital as soon as possible.
Thank you very much, David.
You're welcome. Is that it? Is it?